Welcome, everybody. I would like to acknowledge the traditional custodians of the lands we are all meeting on today and pay respects to their elders past, present and emerging. I am on the land of the Kaurna people and pay my respects and acknowledge their ongoing spiritual connection to this land. I extend this respect to all Aboriginal and Torres Strait Islander people in attendance today. Welcome to CHF's 2020 Members Policy Forum, which this year is a virtual meeting because of COVID provisions. We are very happy today to welcome our members and members' organisations from all around the country. Thank you all for coming together today to share your thoughts, your insights and your ideas about how we can work together to represent the interests of Australian healthcare consumers. There are three parts to this Members Forum. The first session is the launch of our Making Health Better Together report from our Consumer Commission. You'll hear some personal reflections from four of the commissioners, and Leanne Wells will take you through the key recommendations. This launch will be followed with a presentation from Professor Brendan Murphy, the Secretary of the Department of Health, outlining his priorities for health into the future. And the last session is a workshop from our partners at the NH&MRC Partnership Centre for Health System Sustainability, who will be teaching us about the important topic of implementation science. So we have a packed schedule ahead of us, and I hope you're all keen to get started. Starting with the Consumer Commission. This commission was established by the CHF in the wake of the COVID-19 pandemic to ensure a strong consumer voice was helping to shape healthcare moving forward. CHF believes that meaningful partnerships with consumers are critical to ensure we reimagine health and social care in a way that is person-centred and person-led after this significant period of disruption. The Commission is a diverse group of 30 consumer leaders from across Australia, drawn from our membership and our networks, who came together in a number of workshops to look at how we can reimagine health and social care for the benefits of consumers and carers as we move through and beyond COVID-19. Of course, we are now living in the new COVID-19 normal, in inverted commas, where health policy and services need to adapt, but remaining hopeful that there will be a time where life will return to normal. The views of commissioners were added to and reinforced by a series of expert stakeholder interviews, and we thank them for their generous input also. The Commission report, Making Health Better Together, is being released today. It presents a range of structural and practical changes to support the health and social care system into the future. The Consumer Commissioners all put an enormous amount of work into the process, and CHF would like to acknowledge their hard work and their generosity in sharing their ideas and working together intensively over a relatively short period of time. So we're now going to show you a video where you'll hear reflection from four of the commissioners on the experience and the key recommendations. I'm Tony Lawson, and I'm chair of the Consumers Health Forum of Australia. And I also chaired the Consumer Commission that CHF established earlier this year to identify the lessons for consumers from COVID-19. A number of things came out of that process for me, but there are three key things that I wanted to mention. Firstly, was that we had a group of really experienced and wise and committed consumers who contributed to the process. Secondly, the process that we used was demonstrated a really good way to engage and involve our consumer commissioners. And thirdly, I believe that the outcomes of the commission will result in greater respect for consumer input into major health issues in our country. It now gives me great pleasure to hand over to 4 of our 30 commissioners for their brief insights.
I really enjoyed the discussion around health equity as part of the Consumer Commission. There was a lot of discussion around health promotion, prevention, and action on the social determinants of health to address the health inequities that we see across Australia in terms of vulnerable and marginalised communities. We heard about recommendations for social prescribing, which is really important. We've heard about needing at least a 5% of total budget spend in that health promotion and prevention space as we move towards 2030. So I'm really looking forward to the opportunities that linking that to the National Preventative Health Strategy can bring coming out of the back end of this important Consumer Commission work.
Consumer leadership and authentic partnership are essential. It needs to be embedded into all elements of the health system via leadership, via co-creation opportunities, and via formal governance structures. The establishment of an independently governed National Health Consumer Leadership Academy will not only create an opportunity for patients and health consumers to share the great depth of knowledge that they bring in terms of their lived experience, but it would also give greater confidence, skill development, and peer support opportunities to all of the health consumers and patients who want to participate in improving health, in enhancing patient experience, and ensuring that in working together, we achieve so much through our partnerships.
I think digital technologies was the most interesting conversation from my point of view, and the way that they're offering users of the health system safe and timely access to appropriate care with literally the touch of a button. The recent COVID-19 pandemic allowed millions of Australians the opportunity to become accustomed to the resource, and their overall response was pretty positive. So there was an overall feeling that the health system needs to support continuing advancements in digital technologies and ongoing training, not only for the patients in how to use this resource, but for the health practitioners alike who need to understand the differences between face-to-face consultations and these online opportunities. We need to ensure that it's available for those who need it the most, where they need it, but particularly when they need it.
We have a genuine opportunity to step change the way we deliver healthcare and achieve something we all want. Illness is hard enough. As people move through their personal illness experiences, both patients and clinicians want healthcare services to be available, coordinated, easy to receive, and seamless. Everyone wants healthcare that comes together when patients need it and regardless of where the services are coming from. And it starts with the way we invest in health. One of the most significant recommendations from the Consumer Commission for me was about the funding, wherever it's coming from, to come together and lead the change. Rather than follow the money, we have the chance to use the money differently to follow the patient and drive the change patients need. And that's exciting.
Consumer insights are a powerful way to achieve change. They come with no vested interest, just lived experience and better ideas for how we can improve healthcare. There's no doubt that COVID has been a big disruptor for health. It's stimulated a lot of change. Some of that change we want to retain. Some of that change exposed fault lines that we are really concerned about. And some of those changes prompted us to rethink how we can improve healthcare. So that's what we put to our Consumer Commission. What are some of the structural, practical changes that we want to see come out of the COVID experience that endure in health policy and health services for the future? You've heard some very rich ideas, and some of the ideas from the consumers from our consumer colleagues just now. But there's many more full and rich ideas in the full Commission report. I'd really urge you to read it and use it for your own advocacy And I'd like to conclude by thanking the Consumer Commissioners for their generous time, thanking the many, many experts we also interviewed in the process of putting the report together.
Leanne will now give an overview of the recommendations from the report, and the report will be available on our website at the conclusion of this webinar. Over to you, Leanne.
Thanks, Tony. I've just got a little slide here that I wanted to share with people in order to take you through the recommendations, and hopefully we will get a response from Professor Murphy as head of the health department to some of these when he comes online to talk to us at 12 o'clock. Look, I think the first point to make is really that when you're in the business of trying to influence policy, it's very easy often, particularly when you've got the membership base that we have and the consumer networks that we have, to describe and talk about the issues. And the issues are many and varied, as we all know. You know, we cover the spectrum from anything from medicine safety to primary care reform to medical devices regulation through to quality and safety issues, population health. The spectrum is broad because everything about healthcare touches people and their families and their communities. What's more difficult and more challenging is to develop recommendations that ideally can get some traction with governments or third parties that can influence governments alongside peak bodies like ourselves, because often, you know, when governments see consensus coming from clinicians and consumers and other organisations, it's an indication, one, that there's an issue that really does need to be addressed. But if there's particularly consensus on some of the solutions, then that's a good thing. So we did run a very rigorous process with the Consumer Commissioners. As Tony said, we conducted a series of national expert interviews as well in the process of compiling this report. We spent 6 pretty intensive, and I'm sure the commissioners would agree, but enjoyable workshops facilitated in a very skilled way by Andrew Hollow, and I must acknowledge his skills in keeping us organised and focused and on topic. So there were 6 rigorous workshops where we looked at solutions to the issues that have been raised across the many, many years of Consumer Health Forum's existence, across the many, many research projects and consultations we do. And they were underscored by the issues that the Consumer Commissioners said in their expressions of interest that they wanted to talk about. I probably should mention the process by which we engaged the Consumer Commissioners too. That was very much an open and transparent expression of interest process. We were oversubscribed. We were looking for about 30 commissioners, and they were selected by an independent panel. The CHF Secretariat we weren't involved in determining who became Consumer Commissioners. And as part of their expression of interest process, we asked them what were the really pressing issues, particularly in the COVID context, that they felt there needed to be some policy discussion around. And the 3, or actually there's more than 3 there, I can't count. The 4 main areas that they nominated were mental health and wellbeing, health equity, digital health, and integration and care coordination. As we went along, issues and ideas for how to improve and enhance consumer leadership and co-design came forward as a very strong area where the commissioners wanted to make some recommendations, as did governance and national leadership. So you've got here recommendations on a slide, a single slide. There's a lot more richness and discussion and detail behind these in the report itself. So these are the top line recommendations. So you can see there we've gone quite macro on one level with some recommendations around what needs to happen to strengthen and ensure that governance and national leadership is more centrally focused on consumer interests. So recommendations there relating to taking adopting a health in all policies approach, for example, producing a wellbeing budget and report card, a bit similar to the approach taken in New Zealand, looking at how we can better coordinate across government, empowering young people to be partners in the COVID response and recovery. So really giving young people a voice and also supporting young people as our future generation, I guess, of emerging consumer advocates. And linked to that, better investment in training, resources and support to build consumer capacity and capability. An innovative idea that came forward that we're very intrigued by and very keen to pursue further is the idea of a consumer leadership academy. There are exemplars of this type of thing in countries in overseas that we're keen to have a look at, and keen to look at how something like that or an adaptation of something like that could be contemplated in Australia. For example, mental health and wellbeing. Well, we've seen the big landmark report from the Productivity Commission last week, extremely comprehensive, really commanding a comprehensive response from government, not one that picks the eyes out of the series of recommendations there. But the headlines that came from the Consumer Commission were the need to re-skew our investment, I suppose, keep investment in acute and primary care mental health services, but invest much more comprehensively in mental health and suicide prevention services with a focus on early intervention, getting in early. The Commission has looked at workforce and the need to expand the role of peer support and peer workforce across the mental health workforce spectrum. To look at embedding mental health and wellbeing focus into COVID recovery plans, and to partner with consumers to develop accountability indicators for mental health, suicide prevention and wellbeing services. Integration and care coordination won't be a surprise to anyone on this call, I wouldn't think. If there's one plea we hear from consumers time and time again, it's how fragmented and disconnected the system is, becoming increasingly more difficult to navigate when you're talking about, traversing the chasms, and they are often chasms between hospital and aged care and hospital back to primary care. So adopting blended funding approaches that incentivise consumer-centred team-based care. We need to get the system very much geared around teams working for consumers and with consumers, and that needs funding reform. We need and there was strong support for the idea of primary health networks and local hospital networks or local hospital districts being equipped and being given the mandate to jointly plan and co-commission. That's happening in some areas already, we know that, and it's showing great promise, but there was certainly a view that needed to be much more accelerated. Investing in a network of care coordinators and health system navigators, and importantly, packaging that all up, I suppose, into the 10-year National Primary Care Plan that's currently under investment. And for that plan to be not just another strategy, but an actual plan that has an implementation roadmap and a commitment to funding. Health equity, again, another core issue and concern for consumers. So some of the recommendations here from the commissioners, and this is all about the impacts of the social determinants of health, inequity in access. We're all familiar with the issues, but reflecting the fact that CHF had been a strong supporter of ACOS's Raise the Rate campaign for New Start, strong recommendation from the commissioners about permanently increasing income support payments. The urgency around building more social housing to meet demand, broadening the Australian Charter of Healthcare Rights to include a right to health as well as a right to healthcare, and I think that's a very important distinction, an enhancement or suggested enhancement to that charter, and joining with the lead that organisations like the Public Health Association of Australia have taken on this point, and as James said in the video, much more serious investment in prevention to at least 5% of overall health spending, and for there to be some sort of independent payback style mechanism, if you like, for determining what the prevention best buys would be for that funding in the interests of better health for consumers in the community. And then finally, as Ben discussed, digital health and virtual healthcare and telehealth and all of the services that sit under that basket. There was a concern, and we all observed the accelerated implementation of telehealth in COVID and welcomed that. But you know, the discussion needs to really now turn to what is safe, what is high quality, and how can telehealth be continued and embedded, because at the moment, even though we've heard some very, very positive comments from Minister Hunt, those telehealth MBS items for GPs, allied health and specialists are still only temporary. So, and that's that second point, really about providing ongoing access to telehealth, but also looking to the future, providing ongoing equitable access to virtual healthcare for all. I think there's a big concern coming through among the commissioners that telehealth and virtual care shouldn't be a privilege, it should be a right, as all universal healthcare is under our system. And interoperability of digital platforms so that information can be shared appropriately with the right privacy and protections, obviously, but in the interests of better integrating the system. So that's just a really quick flavour and tour through the many recommendations, or the highlight recommendations from the commissioners. All of these recommendations, I think it's very safe to say, were very much backed up strongly, a lot of consensus from the series of experts that we interviewed as part of putting the report together as well. So lots of convergence, I think, around the ideas in the report. So I'd encourage you, as Tony said, to have a look at it. In terms of our next step, these reports are not ends in themselves, but what are we going to do with it? We'll be releasing it today with a media release. We'll be wanting to engage the Federal Health Department and the health policy area of the Department of Prime Minister and Cabinet on its suggestions and thoughts. And we've also written and have been in contact with Minister Hunt's office and had a favourable response about convening a roundtable with him and involving some of the consumer commissioners in a discussion with him about the report and its recommendations. So that's the forward plan. And again, thank you to all our contributors and to all the CHF team here in the Secretariat office who worked behind the scenes to very high standards to support the commissioners to bring this report about. I think back to you, Tony.
Okay, thanks, Leanne. And I reiterate point you made about the fantastic job that all the commissioners did, Andrew Hollow's terrific facilitation, and the work of the staff of the Secretariat in compiling all this amazing set of recommendations. And the other thing I think that we will be doing as a board of CHF is taking a lot of those recommendations that actually have dollars associated with them and start building up a business case and detailed budgets requirements for those to put to government. Hopefully we'll be invited to do that, but we might start the process as soon as we can. So we've got Dr. Murphy joining us at 11:30. It's 11 or 12 o'clock your time. I'm half an hour behind you. So hopefully he will be joining us shortly. What are we doing with 5 minutes?
You've got about 4 minutes, Tony, so we might want to take some commentary. The Q&A box is live and operational, so if anyone has a comment or a question they'd like to ask about the report or ask of CHF while we wait for Professor Murphy, we could do that. question there in the Q&A box, Tony, one for the board, I would suggest. Will CHF be continuing the Consumer Commission?
That's a good question. I think we probably need to see the lay of the land in terms of response to it, and in terms of the policy questions that come out of it, there may very well be a need for us to regroup and consult with our commissioners on policy prescriptions that might come forward. Notice that Brendan is now joining us.
Brendan.
Hello.
Hi, Brendan.
Hi.
So we've got a webinar with a number of participants. Brendan, I may start the process of welcoming you. So we have Dr. Brendan Murphy, the Secretary of the Department of Health, to join us and give us his views on and priorities in the health sector. Just start with a brief bio on Dr. Murphy. Brendan commenced as Secretary of the Department of Health on the 13th of July this year. Prior to his appointment as Secretary, Brendan was the Chief Medical Officer for the Australian Government, and prior to this, the Chief Executive Officer of Austin Health in Victoria. Dr. Murphy is a Professorial Associate with the title of Professor at the University of Melbourne, an Adjunct Professor at Monash University, a Fellow of the Australian Academy of Health and Medical Sciences, a Fellow of the Royal Australian College of Physicians, and a member of the Australian Institute of Company Directors. What do you do in your spare time, Brendan? He was formerly CMO and Director of Nephrology at St Vincent's Health, and sat on the boards of the Centenary Institute, Health Workforce Australia, the Florey Institute of Neuroscience and Mental Health, the Olivia Newton-John Cancer Research Institute, and the Victorian Comprehensive Cancer Centre. He's also a former president of the Australian and New Zealand Society of Nephrology. Brendan has been declared as ACT's 2020 Australian of the Year. Congratulations. And after Dr. Murphy has addressed us, he has agreed to take some questions. So please put any questions you have for Dr. Murphy in the Q&A box at the bottom of your screen. So over to you, Brendan. Thank you.
Thanks very much, and I hope you can all hear me well. So I was asked originally to talk a little bit about reflecting on Australia's COVID response and some of the challenges going forward. I plan to perhaps talk for about 15 minutes or so and have that 15 minutes of questions. So I think clearly from in the COVID position at the moment, we're in a good place. It's actually looking increasingly good comparing us to the Northern Hemisphere at the moment, which is looking pretty frightening. So I think it's worth reflecting on what we did well and what we could have done better, I suppose, and what the impacts are on the health system and the health reform agenda going forward. So I think the reason we did well is that we were very flexible with our approach. We were prepared though, so we got going with testing very early, and we were able to sort of control and isolate all those original cases from China. We took some very brave decisions around border closures, which most countries didn't agree with at the time, and so we really were able to control that first wave of the virus very well, and really most of the country eliminated it, whereas the rest of the world, who had much bigger first waves, didn't ever get rid of it. And so now, as the Northern Hemisphere comes into winter, they're all seeing very, very serious and very troubling outbreaks again. Obviously in Victoria, the second wave was a big challenge for us, and I think there's some lessons learned out of that. One was that that the quarantining of returning travellers is an intensely risky business, and we've seen that happening also in South Australia. And then, of course, the thing that happened in Victoria was that their public health response became overwhelmed very quickly, and then we saw perhaps the worst tragedy of our COVID outbreak were the deaths in aged care. Once this virus gets into aged care, it really has about a 40% mortality rate with people of that age. So that was, and that required that very intense and very, very aggressive lockdown in Victoria, which we'd had hoped to avoid doing at any stage, but was necessary in Victoria. So they're now in a great position. They've come out of their lockdown. They've essentially eliminated the virus at present. And most of the country's in a good place. But I think we know that it's not permanent elimination, given the international scene and all our returning travellers is a false idol. And we will get further outbreaks, as we did in Adelaide just recently. We are continuing to see cases in hotel quarantine, and there will probably be further breaches. So I think one of the messages that we're trying to get out there is that until we've got our vaccine situation and we've got the virus under control across the world, we can't lose vigilance. And the idea that you can, just by closing a state border or having an international border closed, and you can go back to normal life is unrealistic. We all have to continue to keep these sort of as little restriction as possible, but some of those careful behaviours like those QR codes in restaurants and everything going through. I might talk a bit about vaccines and then come back to some of the broader health system implications of the COVID pandemic. Vaccines, we were all pretty wary about putting much hope in vaccines 6 months ago because there's never been a successful coronavirus vaccine even for the previous ones like SARS and MERS. But I think the feeling is now that it's a lot more optimistic. The 2 mRNA vaccines that are a vaccine that's never been used in humans before, they seem to be actually preventing transmission of the virus, which is perhaps more than we'd hoped. We thought many of the early vaccines might just be effective in preventing serious disease, but not stop the virus transmitting. So if you can prevent it being passed from one person to another, that is a really powerful tool. And if things go really well, it's quite possible now that we could have a well-vaccinated population by the end of next year. But that's still quite a long way away. And in that meantime, we're probably going to have to live with international border restrictions and the risk of further outbreaks. But we will likely get some vaccination going in the first quarter of next year. So going back to the more general thing, I think one of the things we learned during COVID in the health system space generally was we had to put a pause on a lot of our reform work. A lot of the things like the medical workforce strategy, the primary care reform agenda, some of the mental health reform work, all of that was sort of put on ice for a while and delayed. On the other hand, in the response to COVID, we did some things that we did much more quickly than we would normally have thought. So, for example, telemedicine is here to stay now, and that was rolled out because people didn't want to go out for their homes in that first wave. Doctors didn't want to be exposed to the virus, so we set up a broad-based telemedicine service, which is going to continue. The minister's committed to making it continue. We're obviously pretty anxious about that because 2 reasons. One is finance are anxious because of the financial risk of telephone consultations, and the other risk I think we've got to be aware of is the quality and safety risk of somebody having a phone consultation where they can't be seen or interacted with, and maybe the risk of missing something and in a clinical consultation. On the other hand, though, it makes it so much easier for a consumer. If all you need is a repeat prescription or to get your blood test result, and in the past you've had to take 2 hours off work and go and sit waiting in a waiting room for a GP. Now you can just book in a phone consultation from your workplace and get some of those simple things done really well. So we're trying to work out how to make telehealth work. We're very keen on video as a preferred method because there is something about having that visual interaction, but obviously we've got to be wary of differences in access. You know, there are some people who don't have technology, and so therefore the minister's pretty keen that we keep some form of telephone consultation in a controlled way. And as you know, we're worried about some of the corporate practices setting up internet, sort of chatbot style medicine. So there's now a requirement that to have a telephone consultation or telemedicine consultation with a GP, you have to have an existing relationship with that GP. So that's one of the reforms that will be here to stay, and that's obviously had impact on our primary care reform agenda. That's probably the biggest thing that we're focusing on as a department and government, is making sure that we continue to make primary care stronger, more attractive, not just for doctors, but for all health professionals, and try and build those comprehensive primary care practices with allied health, nursing, doctors, and try and address the issue of the shortages of doctors and other health professionals in remote and regional areas. And so that reform agenda is now being very, very well advanced. I just noticing, I was reading your commission report. I know you just launched it, and I think it's great work. And I think the issues that you've outlined there are all very important to government. And I think the commitment that we have as a department to consumer engagement and co-design is really important. And sometimes we forget, sometimes, and particularly I think during the COVID stuff, when we rushed things out, we had to be reminded often about the incredible importance of the consumer voice. One of the areas that I might flag was when we were trying to deal with the Victorian aged care response, and we set up our aged care advisory committee, and there was an interesting dilemma between the providers who wanted to, above anything, to protect from bringing virus into the aged care facilities, but what they ended up doing is locking down the facilities and refusing to let any visitors come in at all, which for demented people who might have been in the last few months of their life was a pretty traumatic thing. So we had to try and get that balance between risk of virus plus mental health and consumer experience, and that's where consumer voices and COTA played a really important role in helping us get that balance right. Care coordination, I think, is a really challenging place, and as I said before, the primary care reform agenda is crucially important to us. We did have our voluntary patient enrolment plan, which has sort of now been subsumed a bit by the continuation of telemedicine, but we do want to have a program of enrolment, and again trying to move progressively to blended care models. I think the Australian public is very committed to fee-for-service models for Medicare and PBS, and I don't think any government's going to move away from the primary basis, but we do accept that some of the models of care, particularly in primary care, would be better delivered by a blended payment model. So we're really keen to look at that, and keen to continue to strengthen the role of primary health networks. In the mental health space, we've just been having lots of discussions about the Productivity Commission report, which clearly points to the need to link better the PHN-run mental health services with those that are run by the local health networks. And we've appointed a Deputy Chief Medical Officer in the Commonwealth, Professor Ruth Fine, who used to run a large state area mental health service, primarily for her to provide that drive for us to connect our services to it. For too long, the Commonwealth has funded discrete mental health services. We fund over half a, $5.7 billion worth of mental health services, but they don't always connect very well to the state services. And there's often, lots of discussion about people falling through the gaps and how we need to improve that. I noticed digital health is also in your commission report, and we've just appointed a really exciting new CEO of Australian Digital Health Agency, Amanda Catamol, who has got extraordinary plans to try and make the Digital Health Agency much more relevant and have My Health Record better used. We know that My Health Record is, most people now have access to one, but we do know that it's not widely used by a lot of consumers and by a lot of health practitioners. And we have to make it'll only be used if we make it more valuable. And that's obviously making the information that's in it more accessible and valuable, making the access to it more easier. And also, I think we have to look at how we re-platform it. It's a reasonably old technology now, and we need to make it much more user-friendly, because the potential that comes from having My Health Record, particularly now that we have the telehealth things continuing, and we have increasing uptake of electronic health records in the hospital system. Most general practices already have electronic health records, and that interconnectedness is a really big challenge. So you might want to, at some stage in one of your meetings, invite Amanda Catamol to come and have a talk to you, because she's very, very, very exciting, and we know that there's lots to be done in that space. And then obviously the equity thing is a critically important one. We just spent an hour with Minister Hunt looking at our Indigenous health strategy and looking at our closing the gap targets, and those which we are meeting and those which we aren't. But clearly there are big challenges in equity. Just finally, just going back to the COVID thing, I think the thing that probably has been most rewarding for me about our COVID response is how the Australian population generally has responded. We have tried the whole way through to be transparent. We've tried not to frighten the population. We've tried to tell people what we do know, and more importantly, what we don't know. We've asked them to join us in adopting COVID-safe behaviours. We've asked them to undertake some terrible things like the big first wave lockdowns and the big second wave lockdown in Victoria. The impact of that's had on jobs, it's had on mental health, has been huge. But the Australian population has stuck with us, and it's been really rewarding to me to see the reasonably high level of trust in health officials and in governments that we've seen in Australia. And if you compare that to the United States, for example, or even some parts of Europe, I think that's been such a big part of our story. And so I think the population generally probably deserves the biggest credit for our success story. And there's a lesson in that for governments, that if you bring the population and the consumers with you. And my final message would be, if you get frustrated, by the reform agenda, and sometimes governments seem to be reluctant to institute reforms when there are vested interests in stakeholders, there's nothing more powerful than a strong consumer voice advocating for that. And a civil society movement and a strong civil society push for health reform, which is what you represent, is something that we very much need, and I'm very keen to support and to continue to engage with you. So that's 15 minutes, so I might stop, and I'm very happy to take questions.
Yeah, thank you, Brendan. Leanne, will you now facilitate the question and answer session?
I will, and thank you very much for that, Brendan, and thanks for your recognition of the report. And I know you've probably got lots of things coming across your desk, but there was a lot of time and effort put into that report, and yeah, we certainly hope the department and the minister find the recommendations both insightful, and they're certainly coming from the point you raised about, you know, a strong civil society voice for health reform. So I've got lots of questions in the chat box and in the QA box, which is fantastic. I might just take it from the top if that's okay. So not surprising, because it was the big disruption of COVID, one of the big disruptions, but telehealth, telemedicine, digital, quite a few questions around this, Brendan. So I might just get your thoughts on the first one. From Mark Diamond, has there been any advance on removing the requirement for a face-to-face contact with the practitioner in order to access telehealth? For many in remote Australia, this is impossible. Surely there are other measures available to ensure quality than excluding access for the people with the worst health outcomes.
Yeah, so I think we're working through that. As I said before, the challenge was that there were corporatized practices that were setting up, offering, you know, log onto our website for a telemedicine consultation and we'll give you a medical certificate and a prescription. And they were very unsafe practices, and there is an inherent risk for, you know, particularly having a new consultation with someone that you haven't seen just on the phone. Now, we are aware of some of the deficiencies that blunt restriction imposed. You know, there are some, again, rural and remote, obviously, but in fact, it's interesting that the rural doctors and a lot of the remote area people actually quite support that restriction, because they're a bit worried about, again, the impact of having open access to remote telemedicine might actually exacerbate the decline in on-site medical attention in rural and remote areas. So we are trying to, I think reproductive health, Murray Stopes have been very, very vocal about the fact that they run online access to abortifacient drugs, and they feel that, you know, people aren't going to have a pre-existing relationship with those doctors. So as we look forward to the primary care, the maintenance of telehealth and the longer term strategy, which will be coming to next year's budget, we are trying to look at those perverse outcomes, but we don't want to have just unrestricted access to any doctor online. I think there is a good safety and quality basis for having a relationship.
Thanks, Brendan. And another one related to telehealth again, and this is, and I think we you know, definitions and issues around scope are obviously important. This is a comment from Susanna Morris, and she noted that you were using the term telemedicine, not telehealth, in when you were talking about the commitment for the future. I expect the answer is no, it wasn't your intent to have a narrow definition of that, but just a comment from you really about how important it is for the thinking and policy around digital health to be thinking and be framed around telehealth and innovation in the use of digital technologies across the spectrum, including you know, access to information, support for consumer self-management, as well as telehealth and virtual modes as adjuncts to existing and you know, future models of care we might contemplate.
Yeah, no, absolutely. And I drop into that telemedicine term because that's what we used in our MBS descriptions. But telehealth, again, one of the best examples of that has been in the mental health space. What we've found during COVID is that there's been huge uptake of digital mental health services, people accessing self-help, and in fact, there's quite good evidence now that for lower acuity, less severe mental health conditions, that sort of approach can be really effective. And again, if you combine that with a triage to get professional help as well, and the potential is huge, as you say, to use a digital interface, not just to have clinical consultations, but to do self-management. And that's all the sort of stuff that Amanda Catamol is really keen to look at in the Digital Health Agency. And I'll be careful with my language.
And just, you mentioned My Health Record, Brendan, and its accessibility and use, and you talk particularly about, you know, making it more user-friendly, because utility with all of these things is where the main game is. It's a question from Janelle Bowden. Are there any thoughts to making the information available through an app rather than a website?
Yeah, well, there are currently apps that you can access your My Health record. I've got one on my phone. There are a number of approved apps that allow, you've got to go through that MyGov stuff to get it authenticated, but once it's done, so there are several approved apps now. And if you look at the Digital Health Agency website, they can give you information about those. But fundamentally, the problem still is, I think the platform is quite old, and it needs to be updated. But the apps are here.
Thank you for that response. Question from, they're flooding in now, quick and fast. Tony McBride, does the department have any plans to encourage GP practices and allied health services to work more closely together to enable a coordinated care approach?
Yeah, yes, I think one of the things that we're trying to do is to actually have this concept of an integrated primary care service where it's not just a GP and a receptionist and maybe a practice nurse, but there is a whole team of allied health people working in a practice. This can include pharmacists, occupational therapists, physios, psychologists. And so we have, one of the things we've done recently is expand our workforce incentive program, where we give primary care practices some annual cash grants to employ non-medical practitioners. At the moment, I think most GPs are still fairly attracted to the model of practice nurses, but increasingly we're starting to see some of them, invest in small-scale engagement of allied health practitioners. The challenge, of course, with allied health is that, and the allied health groups will say this very strongly to us, that they don't have access to Medicare other than through the chronic disease management programs, but that does provide some access, and it does provide a link to primary care. But I think clearly the model of care has to be, in primary care particularly, has to be a multidisciplinary one where if we get the payment models right and the funding models right, that if you can go to a primary care centre and access an allied health service if that's what you need, rather than necessarily having everything medically directed.
And Brendan, I'll come back to a couple of other questions in a minute, but there was strong Consumer Commission support for the idea of a Consumer Leadership Academy, and you talked about the importance of a strong civil society voice. Part of that is reliant on consumer advocates with leadership and effective advocacy skills to have an impact and influence on the system. Is that a concept that you would support, or just interested in your thoughts? I'm sure the commissioners are on the concept of a Consumer Leadership Academy.
Look, I think it's a good idea. It's an interesting idea. Obviously, whether we did it would be a decision for government. And I've only read your report this morning. I'm quite attracted to the idea, and I just need to sort of think it through and think through the implications of it. And it's something that I'm sure your report will be considered by Minister Hunt, and something that we'll want to discuss with him. But I'm absolutely committed to the idea of strong civil society in health reform. I think if you go back and look at those countries that have done very well in obesity prevention, strange one, Mexico has probably done pretty well compared to many countries, and the single biggest difference between Mexico and other countries that haven't done as well as a strong civil society push on that topic. So I think there's huge value in that, and we are often in the health system, we're often overly dominated by loud stakeholders, and the most important stakeholder is the consumer, and I'm absolutely committed to that. I just tell you an anecdote. When I did I had to do my only been 2 months into the job, I had to do my performance review with the head of Prime Minister and Cabinet and the Public Service Commission. You have to nominate some external stakeholders, and I nominated one of your executives, Leanne, who I'd worked with, and they came back to me and said, you know, why have you nominated a consumer? I said, because that is the most important stakeholder we have. So it was a signal to the Prime Minister's department, because that ultimately we're all here for the consumer, and occasionally some of our health stakeholders don't quite remember that all the time.
Well, that was a very impressive move, Brendan. We had noted that one. Have you got time for a couple more?
Yes.
Another question here: medicines and access to medicines and subsidised medicines, and you know, the whole quality use of medicines agenda is an important issue for consumers as well. The government has indicated that it would undertake a review of the national medicines policy. Can you tell us when we might see that review commence?
Yeah, it's very soon. It's starting pretty much now with the early planning work, and will be well underway next year. So there's a lot of interest in it, and I'm hoping that it'll be we'll get some outcome from it next calendar year. But it's getting underway now. Our TAD division that Penny Shakespeare runs, and the TGA are partnering on setting that up.
Okay, and a question also about how will the department consult with young people about their needs in relation to mental health and wellbeing during the recovery from COVID, including the need for them to be vaccinated once the vaccine is available?
So on the vaccines place, we are doing a lot of market research right at the moment, looking at all the sort of populations that we might want vaccinated, including specific work on young people, specific work on older people, and on, you know, trying to determine the vaccine hesitancy. And as you say, young people, the only reason for most young people to be vaccinated would be to protect the rest of the community. Mm-hmm. So we're doing that sort of work. We have Minister Colbeck, who is the Minister for Youth, who's been doing, he's actually conducting a youth forum, I think in the near future, to sort of look at some of those youth issues generally in terms of post-COVID and health. And obviously in the response to the Mental Health Productivity Commission, which government will be considering in next May's budget. As you're aware, there's a very strong youth advocacy voice in the mental health professional space, and we sort of need to look again at how we integrate some of the youth programs we've done, such as Headspace, which have been very successful programs, but arguably again aren't linked as well as they could be to the state and territory health services, and so that's a big part of that work.
Thanks, Brendan. We saw some very interesting partnerships occur in COVID. One question here from Shirley Baxter: do you foresee private and public hospitals continuing to work together to keep waiting lists short for surgery? Yeah,
I think that's it. It was a very good partnership. I think particularly in Victoria, where I think we had at one stage 500 residents from aged care facilities in private hospitals who were there to basically enable them to be cohorted, and some of the facilities we had to shut down because they weren't sufficiently well equipped to deal with an outbreak, so that private hospitals were very, very strongly in partnership. And we've seen partnerships in the past between state governments and private hospitals in elective surgery, and I think we will start to see some more contracted elective surgery in the private sector. It's a good model for certain types of surgery. There is obviously a bigger issue about the future viability of the private hospital sector, private health insurance, making it a more attractive and affordable product, one of Minister Hunt's biggest agendas, and so we're doing a lot of reform work in that space. But I think you're right that partnership we established with the private hospital sectors hopefully will continue post-COVID.
And could I come back also to the National Medicine Policy Review. And this is, I suppose, you know, our observation is where there are major government processes at the really highest level of governance, having consumer involvement at that level is really important. A key principle for us, we saw a consumer commissioner on the Productivity Commission inquiry into mental health. There was a consumer panelist on the pharmacy regulation review, independent panel looking at pharmacy pharmacy regulation and remuneration review. Is there likely to be a consumer reviewer as part of the medicines policy review, or is that thinking not?
Look, I'd have to go back and look at how how that's planned, but I will take that as a task to go and have a look. I mean, I think most of our medicines policy space, all the TGA committees, you know, MSAC and PBAC have good consumer representation. It's been very much part of our approach to medicines policy. So prima facie, it would seem sensible.
Part of the DNA, really, isn't it? And should be.
Yeah.
Well, it's 12:32, Brendan. Have you got time for one more, or?
I've got time for one more, yeah.
Okay, let me just quickly flick through here. Expanding, this is from Deborah Letica from WA, expanding on Tony McBride's question about encouraging GP practices and allied health to work more closely together. Does the department have plans to also include specialists in the care team in the exact same way?
Probably not at the moment. I think our focus is very much on primary care reform. The specialist, non-GP specialist practices, where they'll be something we'd look at in the future. I think where the worry at the moment is that, you know, primary care has to be the mainstay of our health system. We've got to make it stronger. We've got to make it more attractive for doctors and other health professionals to work there, and make it more accessible to the community. So at the moment, our focus is very much in primary care.
Mm-hmm. Thank you, and thanks very much for all of those answers. It was, I said at the outset, when we launched the report, you know, it's Consumers Health Forum. We have our interest span, everything from medicines policy to primary care, to prevention, to quality and safety. And I think, you know, we've seen a flavour of that in the questions there, which we didn't get to all of them, but we really appreciate your time today, Brendan. We know you're extremely busy, and for taking Q&A. For those questions we didn't get to, for people online, where we've got explicit questions that we can answer in consultation with the department, we'll get back to you on those. And again, thank you for your time, Brendan. Back to Tony.
Yeah.
Thanks, Leanne.
Yeah. Thanks very much, Brendan. Really appreciate your time and your contribution. Really thrilled to hear you state about the importance of the consumer stakeholders being the most important. That's music to our ears. We're obviously like to follow up with you on the Commission report's recommendations, and we look forward to a really productive relationship with you for the future. So thank you very, very much.
Thanks. Enjoy the rest of your meeting. Okay.
Thanks very
See
much.
you guys.
Bye-bye now.
Bye.
Bye-bye. Okay, we're going to have a 5-minute break, I think. Is that the plan, Leanne? You're on mute.
Yes, we were thinking we'd have a
quick 5-minute break.
Jeffrey.
Okay, and then we'll come back to you, Jeffrey.
5-minute break, and then you can formally introduce Jeffrey and his colleagues and our workshop.
Right.
Thanks, Tony and Leanne. Thank you very much.
Okay, see you in a minute.
5 minutes. people off. Anyway, that's good. Stop. You've stopped it, Anthony. Anthony.
Okay, ready to roll?
Yes.
Jeffrey.
They're back.
Hi, Jeffrey. Okay, we'll make a start on this session. Thanks. It's now my pleasure to introduce the team from the Australian Institute for Health Innovation and the Partnership Centre for Health System Sustainability at the Macquarie University. Implementation science is sometimes described as the way to ensure a good idea gets put into practice. So many good ideas fail because not enough time and effort is put into how they are implemented. This workshop will give you a taste of how implementation science can improve the quality and effectiveness of health services. The presenters are Jeffrey Braithwaite, Professor of Health System Research and Founding Director, Australian Institute of Health Innovation, Macquarie University. Yvonne Sarinsky, Associate Professor of Health System Sustainability, NHMRC Partnership Centre for Health System Sustainability, Australian Institute of Health Innovation, Macquarie University. Francis Rapport, Professor of Health Implementation Science, Centre for Healthcare Resilience and Implementation Science, Australian Institute of Health Innovation, Macquarie University. And Gaston Arnolda, Senior Research Fellow, Centre of Research Excellence for Implementation Science and Oncology, Australian Institute of Health Innovation, Macquarie University. I'll now leave you in their capable hands. Thank you.
Thank you very much, Tony, and thank you very much, Leanne. It's always a pleasure working with CHF, and we're working together on multiple projects simultaneously. But today we got the team together at the Institute to think about implementation science as a masterclass for Consumers Health Forum folks, people associated with Consumers Health Forum. So we've got some slides. I think we've got about an hour and a half for this, a little bit less. We've got some slides we want to walk you through. These are available to you at the end if you want to leaf through them in your own time. But we wanted to also leave some time for discussions. And I heard the Chief Medical Officer say that consumers were at the heart of what they do. We have over the years, as researchers, really imbibed that message. And once upon a time, I think it's true to say a lot of research was done, you know, just because people got trained to do research. They got a PhD and became researchers and did research. Our journey has been to be heavily influenced by CHF, and I hope, Leanne and Tony, we've also given back to CHF as well as getting influenced by you to really orientate our research to start with the patient, to start with the consumer. And just like Brendan was saying, his journey has been to have the consumer as really the object of what he does, the subject of all his work. Same with us. And even though we might be thought of as pointy-headed researchers in the ivory tower of a university, we actually get out there and mix it with people and roll up our sleeves and have consumers on our grants, on our papers. We co-write and co-design with them. So that's an absolute pleasure. We've just published a paper, in fact, is it this morning, Yvonne Sarinsky?
That's correct.
That's
yes.
Good timing. That's good timing. Called Changes in Public Perceptions and Experiences of the Australian Healthcare System, A Decade of Change. And the authors are Leanne and Yvonne and other people around the table. We've sort of, and Joe Root as well. So we've kind of like not just not just say this, we actually believe it, and I hope we walk the talk. But that's by way of a preamble. Let me share my screen and let me walk through with you. I think, Yvonne, this is your computer, so you're going to share the screen better for us. Let me walk through with you the beginning of our talk. Let's just go to presentation. I've got it. Yeah. Yes. Everyone can see that? And you can see me. Okay, fantastic. So as Tony and Leanne said, there's 4 of us on the team. The Institute's quite a large place, but we drew on people who we thought whose work best maps to this idea of implementation science and learning about what's new in that area. So a little bit about us first. For those who don't know, the Institute is a big thriving place. We're here at Macquarie University. There's a wave from some of us. We actually do a lot of health systems research. I think we're the biggest group in this area in the country and really one of the largest groups in the world doing health systems research. So I like to joke that we don't look down microscopes or have test tubes. Our laboratory for our research is the health system. So we're not stuck in a laboratory somewhere. We have lots of centres within our overall institute. So we have 3 university centres, one run by me on resilience and implementation science, one run by Enrico Coira on health informatics, and one run by Joanna Westbrook on health systems and safety research. And then we've got a lot of flagship NHMRC, National Health and Medical Research Council, and Medical Research Future Fund centres, which the government funds for different topics that we do research on. And each of these is heavily skewed and focused on consumer needs, consumer interests, and has consumer involvement. So the one that we're doing this particular talk in partnership with is the Partnership Centre for Health System Sustainability, and we'll talk a bit more about that. But we have other research grants and centres on keeping people out of hospital, aged care, implementation science in oncology, getting more cancer care being evidence-based, digital health, connecting up the health system, researching how connected up it could be, and digital support for aged care. So lots and lots of research going on different important topics, some of which the Chief Medical Officer covered. So the Partnership Centre for Health System Sustainability, which is really a flagship $10 million grant, which is a lot of money with lots and lots of partners, including CHF, is funded to try and see how we might create the system which is built to last and which is a better health system than the one we have today. We know the health system today is very good at a number of things, but it could do better. And I think every consumer can tell that story, of course. So we're working on that with a lot of partners to try and create a system that we're using this idea of sustainability, a health system that's built to last and is future focused and solve some of the problems that we know exist in the current system. So just an overview of this particular part of our work, the Partnership Centre in Health System Sustainability, a very big, important piece of our work. We've got 17 lead investigators, including Leanne, 7 research leads, 6 system lead investigators, 4 designated system-based investigators, that people who are investigators on the grant, research investigators, but they're in the system, trying to make it work better. We've got lots of expert advisors and system implementation partners around the country. Now, they're people that you would know and love. They're the colleges, the medical and nursing colleges. They are the pathology providers. They are the jurisdictions, the health departments in the states. So lots and lots of people whose work it is to run the system are working with us productively and collaboratively to help research the system to make it a better health system. We do 3 main things in this grant, although I must say, it's true to say, Yvonne, we do a lot more things in this grant. We do three main things. We look at data. It's got lots of technical names: analytics, technology, shared information, shared data. What it means is, can we have a better system that's better connected, that people can access in better ways? Secondly, is to reduce waste and low value care. That is to say, we know every health system, including Australia's, can produce care that shouldn't happen, or it's just really not of great value to consumers. So can we do less of that? If we can, we'll have more money for the things that are worthwhile to do for consumers. And then the third thing is to create better value for every health dollar. And we've got health economists working with us to try and say, how can we use this very large investment? What is it? Almost $200 billion on healthcare in Australia. That's a lot of money. How can we get better value for that? So every dollar is spent on things worthwhile. So what we want to do is improve the health system by generating evidence to inform change, to change the system for the better. We know that health consumers are our best partners in that because they're actively advocating for a better health system. Many health consumers have had good experiences. You've had an operation on your hip, or some preventive care, a jab when you were a kid to immunize you, or a health system helped deliver your baby, or whatever it was that you used the health system for. Go to a GP on a regular basis. But there's also stories when the system didn't work very well. There's dramatic things like when the system takes somebody's wrong leg off, through to getting an infection if you go into hospital, or having a fall while you're on the watch of a ward, or you get the wrong diagnosis from a GP. So we know that the system produces lots and lots of good things, but it also has things going wrong sometimes. And we don't shy away from that. We try to research both when it goes well and when it goes not so well, with the aim of learning about the system constantly, just like consumers do, and then trying to close the feedback loop of working with the system to improve it. So we publish a lot of reports. We do a lot of things to produce evidence to support consumer advocacy for a better system. So we're really, it's easy to think of us as pointy-headed academics who do nerdy research in an ivory tower, if I can mix metaphors, Tony. That was like 3 metaphors in the same sentence. But we're actually, we like to think of ourselves as one of the greatest partners for health consumers to provide an evidence base to the advocacy that they want to do to produce a better health system. So the Institute itself and its centres is a big enterprise. You know, we've got almost a couple of hundred people doing this sort of research with us. We produce lots and lots of peer-reviewed journal articles in big journals overseas. We do lots of outreach events, educational type events. And Yvonne's slide, this one, Yvonne says, we're the ones who are crazy enough to think we can change the world, and we're the ones that do change the world. Well, you're right, Yvonne. However, we kind of research it, and we work with people who actually can change the world, such as CHF and Brendan Murphy and other people. We'll come on to some of these ideas. So that's the Institute and the Partnership Centre in Health System Sustainability, and some of the things we do by way of providing a profile, an intro. So what about me? So I'm a researcher. As you can see, I'm a relatively young person in my early 20s and only got a PhD a year or so back. Is that a true statement, Tony? Maybe not. I'm a researcher with lots of national and international experience in working out ways to improve care for patients. And I've been able to be, and privileged to be able to do that because of being a health systems researcher for a long time, doing lots and lots of projects. I've done over 100 projects working on different facets of the health system, all the way through from policy at the top of the chain, the sort of thing Brendan does, all the way through to working with clinicians and working with patients on the ground, seeing how we can improve the care that's actually delivered at the clinical coalface. So I do everything from big trials through to small scale or in-depth studies. So what I try to do in a diagram, and this is a diagram that we use a lot in implementation science since we published this paper in 2014, is this. So over time, we want to continuously have a cycle of improvement in the health system so it's better over time than it is today. So the two things on the graph are improvement of some kind. There's lots of different ways you can improve the system through time, continuously improving. So that's what I try to do, and I try to provide research evidence for this. That's what I try to do in one diagram. So what is this thing, implementation science, and why do we need it? Well, we know some facts and figures about the health system that, to be frank, are a bit scary. One thing is about 15 years is what it takes for research evidence to get some level of uptake into clinical practice. So there are 27 million papers in the big medical database called PubMed, containing all the papers that have been published for 50 years or so that researchers like me have produced. 27 million. And of all those papers that are produced, many of which represent good evidence of how we should change the system for the better, only about half of it gets taken up into clinical practice. And even when it does, it takes on average 15 years for it to get into clinical practice. That's scary. It's good that people are producing all this evidence, but it's scary that we don't take as much advantage of it as we could. And that's where we come in. We really try hard to work with people to say, look, this is the evidence for your clinical practice. And with Consumer Health Forum as one of the main advocates we have for our research. So what is this implementation science stuff? Well, it's a lot of things, really. It's really about getting evidence into practice and improving the health system. So you can use technical words, and Frances, who's going to talk a bit later, Professor Frances Rapport, she's published with me a really useful paper on some of these buzz phrases, trying to unbundle them for people. So there's diffusion, that is passively things go through the system, evidence goes through the system, publishing papers in good journals and writing reports for people. There's dissemination, that's more active, that's when you're actively trying to get things into practice. Then there's implementation, where you're much more actively trying to implement something that's good for the system. Say, some evidence about whether to do a knee operation or not. And so that's also known as knowledge translation or translational research. What you're trying to do is take the data, take the evidence in a report or in an academic paper and make it work in the health system for the betterment of care to patients. So that's kind of where we sit. We haven't got a laboratory. We've got the health system to work with and on to try and improve things. So implementation science helps us understand how to do change, when to do change, what the barriers and enablers are, because we know not every clinician practices and does everything that's evidence-based. It helps us to understand who needs to do what, by when and how to make change happen and deliver the right care to the right patient at the right time, etc. And one of the things we also believe is that it should be nothing to me without me, which is a CHF mantra, which we firmly believe as well. So even though we have evidence for something, it should have the opinion and the input of the consumer before anyone does anything to a patient. They should have consent, and it should be something that people want, not just that medicine thinks you need to have. So consumer involvement, as I've said, therefore is really critical. And we're going to talk much more about that with later speakers. But what we know is that we can't really produce all this evidence, write it into a good paper in the New England Journal of Medicine or somewhere famous, You know, that goes really well for us, and we put that on our CV, and then we don't have the expertise or the capacity to actually put this into practice. So that's where the consumer comes in. It needs the consumer's involvement, the consumer's consent before it's produced. And that's where Leanne and Tony and others, Joe Root and others in CHF have been an inspiration for us. So we also talk a lot about doing formative evaluation. And I think Yvonne's going to talk a little more about this. And that is to say, to take a sounding, take an understanding of the system and where it is, and evaluate that, weigh up whether it's doing good, and then feed that back to the system if it isn't. And we're going to give some examples of this shortly. So does what the system want patients to have, does that align with the needs of the consumers, with the consumer's own view of health needs? Now that takes you to all sorts of places like understanding PROMs and PREMs, patient-reported outcomes, and patient-reported experience, because those need to be systematically gathered and then fed back into the system. And increasingly they are, more and more they are, because that's a much better informed health system, taking into account consumers' needs. We've got lots of models. Brendan talked about equality. I think that's a crucial issue. I don't think it's a health system, although the Australian health system is better than most. I don't think it always produces the equality that we need. I don't think sometimes it's as open as we would like it to be, although I got to say, when I was younger, it was a lot less open. I would like to think that patients and consumers get respect and their values and views are acknowledged, but not always. I'd like to think that providers are compassionate, providers of care are compassionate and display empathy, but not always, and we hear reports about that. And I'd like to think that whatever treatment was provided to patients, it was co-designed, not just what medicine thinks you need to have. So those are principles that we work on. Those are principles from the Agency for Clinical Innovation. Those are ideas that we firmly believe. And I've got to say, as researchers, we didn't always believe this. If you go back 15 years, I wouldn't have given this talk. I wouldn't have been as informed about consumer needs as I am today. So remember this one thing, if you remember anything at all from my talk. Implementation is not an event. It's continual adjustment and improvement. We won't just get the health system that patients deserve and that providers need to provide at the drop of a hat. It's far too big and complex for that. There will still be things going wrong in 10 years' time, I've got to say, sadly. However, we can do better than we can today. So we work on this continuous improvement model all the time. So that's what I want to say by virtue of what I am involved in and my perspectives on the system. I'm now going to we're going to do a quick change of seats because we're all in the same room. I'm going to do a quick change of seats and go on to Yvonne, who's going to talk you a bit more about her and her work. Yvonne Zurinsky.
Hi everyone, and thank you very much, Jeffrey, for setting that up so beautifully. Keep in mind those loops, the feedback loops and evaluation that Jeffrey talked about, because I think all of the speakers will hark back to that. So who am I? I'm a researcher and implementation scientist and policy analyst who studies health systems to improve the system for people, families, and for healthcare professionals. I do many different types of research to inform co-design and to investigate new models of care that join up health and community services and simplify people's health journeys through the health system. And I've got an example that I want to show you to demonstrate how that might happen. So this is a study or an implementation science program that we undertook at the Sydney Children's Hospitals Network. So they're the two largest hospitals in Sydney. that form a large network. And there's a link there if you want to look at the actual report. And we looked at integrated care for children with medical complexity. So these are kids who are quite complex. They have complex needs, not only medical needs, but also social needs. And this whole thing started back in 2014 or 15, where children with medical complexity were mostly accessing care from tertiary, quaternary children's hospitals, which are very high cost settings. There was a lack of care coordination, and that led to both missed care and duplicated care. So kids were getting duplicate tests, but some were actually missing out on appointments, particularly those living in rural areas. And the system was relatively inefficient, both for the teams looking after these children and for the families. And so the routine care and routine management we felt could be effectively and safely provided in a local hospital or in primary care at a much lower cost. But parents tended to trust the children's hospitals much more than they trusted their GPs, particularly when they have children with very complex conditions. And of course, parents in regional rural areas travelled hundreds of kilometres to reach the metropolitan hospitals. So this was not a sustainable situation. So remember, Jeffrey mentioned formative evaluation, actually looking at the system to see what it's doing now in order to be able to develop some improvements in the system. So we did a lot of formative evaluation. We did a lot of listening. We did a lot of listening to patients and to parents and to families. And, your stories really matter, because if we truly want to do co-design, we need to understand your story. So, we did the usual things. We looked at electronic medical records, etc. But we also held parents' forums, interviews. We even shadowed some families. So, a nurse or a researcher would walk with the family to understand what their journey actually was when they were accessing services. And it was really interesting what parents and families said. They were repeating their story every time they saw a new provider. They were concerned about what they might do if their child gets unwell during the middle of the night. How are they supposed to access the centre of expertise in the Metropolitan Children's Hospital when they're living out at Dubbo somewhere? And it's interesting that parents actually said it's like running a massive project. It's a project management issue, managing all the different services that provide care for their child. And someone actually said dealing with the hospital has just become too difficult for us to do alone. And we wrote a paper with exactly that title, just reflecting on that. So we listened to parents, but we also, why is this not moving? Here we go. We also felt we needed to talk to the health professionals, because after all, if we want them to change the way that they deliver care to these families, we need to understand their world as well. And they did understand their world to a great extent, actually. They talked about complexity, understanding the family's perspective and being able to put themselves into the family's shoes. And one of the things that kept coming through time and again was that families carry the knowledge about their child with them. And in fact, some of them had hard copy dossiers on their child, which was like a care manual, so that when they turned up to a new emergency department or they saw a new practitioner, they actually gave that to that practitioner. And obviously we thought we could do that in a much better way. So we brought all this information together. And so we listened to the children and families, we listened to health professionals, and we looked at the health system, because changing the system is not easy. So even if families and children want change, and if health professionals want change, that doesn't necessarily happen. The sorts of things that people wanted and that we've put into this model called Kids Guided Personalised Service, so Kids GPS, as in a GPS, you know, it'll take you through the system, hopefully. One of the main things was having a care coordinator, a single point of contact that parents could actually access. Having shared care plans so that all providers could access that care plan. And some of these children had, you know, 13 or 15 different healthcare professionals looking after them. So having that shared plan so that everyone knew what had been done with this child was really important. And the parents actually, we developed an app so the parents actually could share the plan with whoever they saw next, so they didn't have to repeat themselves too much. We added teleconsultations, we added cross-sector partnerships, so we worked with the social care sector, with schools and so on. We also looked at building capacity within the rural regions because families could get care closer to home if the capacity to provide it was there and if the trust was there. So we developed a support system for clinicians working in the rural regions so that there would be much more support between the centre of excellence in the metropolitan hospital and rural regions, for instance. So we did this and we implemented it, but it's not as easy as that. So we have this fantastic model. We need support from other stakeholders as well. You need support from management. You need funding commitments. And you need commitment from those who are funding it, from the children's hospitals and from departments of health to keep this going. Parents didn't want this to be yet another project that has an end at the end of the funding. So we really wanted to keep this going over time. Luckily, this also aligned with statewide policy on integrated care, and we also worked with the workforce. So you really need to be looking at the whole system. So what did we find? Well, strangely enough, we started evaluating at the beginning. In fact, before the beginning. So we did the formative evaluation to understand what was needed, but we didn't stop there. When we started implementing, we had those continuous loops coming back to us, not only from the parents and families, but also from the health professionals and from managers who were looking after this system. We embedded patient-reported outcome measures and patient-reported experience measures as well. And we did some basic health economic analysis as well. That's quite important to show the effects of any new system. Okay, so in terms of the benefits, so this is about 2.5 years later. Parents really loved their smartphone app where they had their shared care plan that they could share with providers. They felt that their journeys were smoother and they needed fewer appointments in the metropolitan hospitals. Lots of kilometres in travel were saved, lots of school absences were prevented. ED presentations decreased by 40%, which is huge if you think about it. And day-only admissions decreased by 42% as well. And of course, we saved some money. So implementation science really helped everyone to understand what was needed by patients and families, but also understand the context that the healthcare professionals work in, and to understand what's happening in the health system at the time, to leverage off that. We identified key enablers and barriers to this model. We tested and evaluated what worked well and what didn't during the implementation process. So we included everyone in that process, families, professionals and managers. And that has helped us to develop a program that will be will be implemented in rural regions called Rural Kids GPS. So without doing that continuous evaluation and applying implementation science perspectives, we probably would not have been able to do this. All right, so I'm going to hand over to Gaston now. Swap.
Hi, everyone. I'm Gaston. I manage the NHMRC Centre for Research Excellence in Implementation Science and Oncology. There's a team of us, some like me with quantitative skills, others with qualitative research strengths, and some health economists. I do research in a number of areas, not just cancer. My background interests in implementation and quality improvement, and I've done that in maternal and child health, and a lot of it's been in developing countries. So a different setting to here, but essentially the same needs we're trying to meet. So the patient at the center of cancer first sort of comes into the writings I've been looking at back in the 1994 Senate Standing Committee and Community Affairs report on breast cancer. And there was a realization in that report that the system, we were mostly concerned about treating a disease, not caring for a patient, and that needed to change. There wasn't a lot of good language for it at that time. But by 2005, we had a report that a different Senate Standing Committee report, also on cancer, which explicitly recognised that services need to be patient-focused and patient-centred. This is captured, I think, really nicely in a 2013 report by the US Institute of Management. And what you see here is that patients are very explicitly at the centre of cancer treatment, and that when we're talking about quality measurement, we're not just talking about morbidity and mortality, we're talking about other patient outcomes. This was also recognised elsewhere in the Anglosphere with the UK. Parts of the NHS are explicitly recognising patient experiences and outcomes as co-equal with morbidity and mortality. So that's a big shift in the way health systems think. So I'm going to talk to you about two areas that the centre I work with is interested in. One is patient-reported outcome measures, and the other is patient experience surveys. In New South Wales, we are in the process of rolling out some patient-related reported outcome measures, something called prompt care, which people with cancer do monthly while they're in active treatment, and then less frequently thereafter. And the data from these get integrated into their medical records electronically and are used for triaging. So if you score really badly on depression, then it's going to send a signal and to the hospital at which you're being treated, and someone will contact you to work out what support needs you need. It's also going to be used in survivorship for coordinating care, because there's so many people are surviving cancer now that there's a long-term cohort that need to be cared for and can't be cared for in the hospitals as they have historically. We need to share that care with GPs. So these reports will also go to GPs in the future. And we also need to look at opportunities to monitor outcomes from them. The other area is patient experience surveys. And in New South Wales, each year this is now the 6th year we're doing it, but each year we approach about 25,000 people who've had outpatient cancer services, and about half of them respond and tell us about their experience. And that helps us to identify what's important to patients and how they rate their care. So this has been happening for a bit longer in the UK, and we've looked at that data while we're waiting for approvals to access the New South Wales data. And so a couple of little highlights here. The UK Cancer Patient Experience Survey had 46 questions that we were able to look at and see how they related to patients' overall ratings of their care. And there were 8 that we found were predicted high ratings of care, and 2 I found fascinating. More than 2, but 2 I want to bring to your attention now. One was whether the clinician had the right paperwork at the most recent outpatient visit. I mean, I love this as just a simple indicator of how people respond to a service, or of how organised or disorganised a service is. The other is the ease of contacting a specialist nurse. So the UK, unlike Australia, every cancer patient is expected to have a specialist nurse. And the picture on the left there is of a Macmillan nurse, and Macmillan's a cancer charity, and they fund positions that the government, on the basis that the government will, after they fund it for the first 3 years, say, take it up and make it a permanent position. So Macmillan funds about, and once they fund the startup of a position, that position becomes a Macmillan nurse forever, even if it becomes an NHS position. About half of the cancer nurses, specialist nurses in the NHS are Macmillan nurses. This is we did a separate analysis of these data, looking just at half the questions that were related to information needs. And we did a sort of a mathematical networking thing of it. But you can see right in the middle there, there's a little rectangle that says satisfaction. And then there's 2 questions that are closely related to that, question 7 and question 19. And they are the 2 things that were most closely related to patient satisfaction. One was receiving a clear explanation of diagnostic test results. So that's often coming to them from their GP. And the second was when you had an important question to ask your clinical nurse specialist, how often have you got answers you could understand? So that's a really interesting finding there. And so it's not good enough just to have a clinical nurse specialist. They have to be trained to be able to answer questions from people from all walks of life, tertiary educated people through people with intellectual disabilities, about what this, what their current need means to them. It also has really important implications for culturally and linguistically diverse people. We know from some research in Germany, for example, that if you're from an ethnic minority and your specialist nurse is from that same minority, you're happier. Lessons for consumer organisations. I mean, broadly, governments have made these commitments to patient-centred care and it's all written down in various places. So really it's consumer organisations that are going to hold them to those, because when it comes down to it, the administrators have to make choices between more medical care, spending money, whatever money becomes available, on more medical care or on more care for that deals with the psychosocial needs of the patients. And so there needs to be pressure from the community if government is going to meet more of those needs. In relation to patient-reported outcomes and experiences, we need to encourage patient participation. UK has about 75% response rates. We've got about 50. We need to monitor reports and demand questions that are useful for patient organisations. And we need to protect the interests of lower participating groups, older people, dying people, non-English speaking people. This is, as you know, we have specialist groups like Cancer Voices in New South Wales that provide a lot of this kind of advocacy, but I thought it'd be useful to go through this for those of you who are not in the cancer area. Let me hand you over to Frances.
Thanks very much, Gaston. So last but not least, you've got me. I'm Frances Rapport, and I also work in health implementation science, like the other speakers that you've met. And I specialise in qualitative research methods, and that's research that really takes a deep dive into understanding people's experiences and people's needs through the things that they tell us and the things that they show us. My research is concentrating on improving health services, but also health systems, and really doing that by making sense of the experiences of consumers, members of the public and patients who all use those services, all of us, you and me. And I'm doing a lot of work in the area of epilepsy. For those of you who know less about this disease, it's a very chronic and debilitating condition. And what's interesting about epilepsy is that it impacts as much on people's mental and emotional health and well-being as it does on their physical health and well-being, whilst people may have a number of comorbidities alongside their experience of epilepsy. And at the most chronic end of the scale is something we call refractory epilepsy. And that's a very dramatic form of the disease where people are not responsive to anti-epileptic drugs and may be having a number of extensive seizures, up to 28 a day. For these people who have refractory epilepsy, that's exacerbated, this experience of extensive seizures is exacerbated. We know this from our research by delays in the system, delays not only between being first diagnosed with refractory epilepsy and being referred to a specialist, but once referred, then getting the treatment they need. And for many people with refractory epilepsy, the only option is to have brain surgery. In fact, these delays take on average 17 years in Australia for somebody with refractory epilepsy to end up having the surgery that they desperately need to either eradicate or reduce those seizures. And on top of that, to make matters worse, once patients enter the system, they can be assessed for up to 2 years with a range of very invasive assessments. So we wanted to do research to understand that whole trajectory that patients go through, to look at what are the treatment gaps, to look at how that impacts on patients' health and well-being and the health and well-being of their families. Because after all, it's not only the patients with a disease that are impacted, but it's everyone around them. And we wanted to look at the resource implications. And we wanted to do a very thorough assessment. So we looked at services and we looked at patients' medical records to understand how individuals are being treated. And as this slide shows, we also conducted a number of qualitative interviews and took part in some very intense observations to see how patients consulted with specialists and to make sense of people's quality of life as they went through the whole of the system. In fact, we worked with 66,000 New South Wales patients between 2011 and 2016, and you can see from this slide, a large number of patients were admitted to hospital with epilepsy, and 5,000 of those had refractory epilepsy. So it affects about a third of the epilepsy population and is hugely expensive to the country, treatment costs of approximately $4,000 and $2 million, with many people being diagnosed eventually and needing treatment related to either their epilepsy or their comorbidity. And a number of those patients had injuries following their seizures. So not only did they have seizures, but they also experienced injuries such as those that were related to falls, which contributed to the complexity of their hospital admission. When we looked at people's medical records, we noticed that on average people were 38 years of age and had been waiting 17.3 years since their initial diagnosis to get the right treatment and to get the right care that was going to be effective and care that was going to help them and their families to manage this awful disease. And from those, only 11 people from the 50 that we looked at in detail through the medical records actually got to the stage where they undertook a surgical procedure, because by the time that their surgery was recognized as being the right procedure, they were either too unwell or too unsure to agree to go through that, or the healthcare professional felt that they'd waited too long and it was too late, with an average wait time between the first visit and the first post-operative visit of 55.8 weeks. So we realized there was a real problem for people living with epilepsy, having to wait up to 18 years to actually get the right effective treatment, experiencing these chronic and uncontrolled seizures, which really has had a profound effect on their lives. It's affected their ability to achieve their personal goals. It's impacted on their mental health, where they became too afraid to explore new treatments. And it's affected their investment in specialist knowledge and care, impacting on their own beliefs in the specialist or in the generalist, and in their own beliefs in their own ability to make decisions. And consequently has led to a lot of mistrust and lack of confidence in the health system and the health service. So through interviews with patients and with clinicians and consultants, we've realized that people are very frustrated. We need much more tailored information. We need a lot of work done in the pre-surgical workup space, that we need to create information that's personalized to individuals' needs, that we can arrive at in liaison with patients and with members of the public, and that people really they really value very factual information where they can take advantage of other people's experiences and other stories about who to turn to and how to do that. And so we developed a model, and in implementation science, we as implementation scientists often do this. We try to drive forward implementation through a rigorous model that tells us how we need to improve services and how those services can improve patients' lives. And we designed a patient-reported implementation science, or a PRIME model, in refractory epilepsy to enable us to undertake a comprehensive assessment of people's reports about their health and well-being, where patients themselves can enable us to understand an individual situation, where we can be sure that the work we do is patient-driven, and where we can be sure that we're going to arrive at a very clear picture of what might be applicable in specific disease conditions, but perhaps also in others. And this is a picture of what PRIME actually looks like. And I'm just going to talk about this slide briefly, but just to show you that it's built on 6 levels that are quite comprehensive, that together add up to a patient model that we feel will drive a system to improve patient care. And as you can see from this slide, there are a lot of question marks along the way where we have gaps in our knowledge and understanding. And the models also enable us to share those gaps with patients and say, hey, we don't know everything. You know, we've learned some things and we can tell you about what we know, but also we want to sort of own up to the fact that there's a lot we don't know, and therefore we need to get your investment again further down the line to tell us, to help us to formulate a more comprehensive picture. As you can see here, there are question marks about how patients move through the system, about how they might be enabled to be more self-managing in their care, about how they might be able to network better. And we also know we have gaps in terms of family experience and family knowledge. And so for future directions, we want to ensure that we can identify refractory epilepsy much earlier, make sure that healthcare professionals, particularly in primary and community spaces, are more informed. We want to have greater emphasis on the person-centered element of care so that care is more appropriate and that there's a more timely assessment. And we want to bring others to bear in this consultation, particularly nurses and particularly patients and members of the public, so that we can drive a firmer, clearer model of care in the future for patients living with epilepsy. I'm just going to pass on now to Jeffrey again, who's going to help us to conclude and bring all of these different conversations together. Thank you.
Thank you, Frances. And for one terrible moment, I thought you were going to set the PRIME model as an exam question for our colleagues, but you'll be pleased to know we don't have a test. We have no multiple choice exam. We do want to share the slides with you though, so that might generate for people some other ideas, or you might have some follow-up questions. We see this more as not us just presenting, but having a dialogue with CHF members and participants who wish to continue to have a discussion with us. And of course, we work with Tony and Joe Root and Leanne all the time. So let me just try and conclude. We are always taken with really the mission that many Consumers Health Forum type organizations across the world have taken on, which is nothing about you without you. I think that's a very powerful message for the health system. We would like to reach out to you because we would like more people who are consumers. Sure, we also are consumers, even though we're researchers, because some of us are older than others. You probably noticed that, and some of us have, knee problems and a few other things. But we would like you as consumers to be on an ongoing basis involved with us. So by way of concluding, and then we've left some time for questions, which I'll get to shortly, and give an opportunity for people to make observations or ask us a question or discuss anything that we've raised. What we would like to do, Leanne, is say, let's give everyone a virtual certificate of achievement. So I would like to hereby, in conjunction with you, Leanne, certify that the participants in the Consumers Health Forum Implementation Science Masterclass are hereby awarded the honorary title of CHF Implementation Scientist. That's, Tony, I'm not sure if that's for putting up with us talking for a whole hour. I think we could firmly say that this could be signed by Leanne and signed by me. And having attended the masterclass on Monday, the 23rd of November, 2022, you have the stamp of approval from us as fellow implementation scientists. And then finally, what do you do now? Well, we thought a lot about this when we were preparing our talk, and here's some things that we would like to suggest to you. Many of you are actually doing this, we know. But if you're a consumer advocate, a newly minted consumer implementation scientist, honorary implementation scientist, look for change opportunities, because that's what we're doing and that's what we think you do best of all, because you're on the ground interfacing with the system. So your capacity to see what's going on is unrivaled. The only people who see all of the health system aren't the providers, it's not the researchers, it's the consumers. Always be prepared, I think, to give your perspective. Your perspective is the most valuable one for us on understanding how the health system works. So give voice. Tell your colleagues and fellow consumers and others about your work, your observations of the system. Enlist others in CHF's enterprise. All consumers in our experience have a story. That's your narrative, and we'd like to encourage you to tell that story. When things are tough, don't give up. Whatever your condition is, whatever your story, whatever your interface with the system, we'd like to say persist. It's very good to continue to do that as a CHF member and participant. And then, because it's all about journeys, not destinations, go again if necessary. So there's our words of advice. We think we haven't really given you words of advice. We've just captured what a good CHF participant and member does anyway. But we hope that's okay to strike an optimistic note at the end of our talk. So Leanne and Tony, that's all we wanted to say. We'll make a copy of the slides available and we're open for business. Questions, comments, observations.
Thanks, Jeffrey. Leanne, do you want to coordinate questions?
I can do that. You can't see the QA box, can you, Jeffrey?
Yes, I think I can, but what I'm going to do is have you do it so I can bring the big team in.
Okay, all right.
Get some people in the picture.
There's some questions here.
You hard for us to huddle?
You can huddle while I
few of us can. We can
read out the first one. And the first one is from someone well known to all of you, one of our shared colleagues, Joe Root. Joe's asking, can you expand on how? It's the good how question. Consumers can become consumer researchers. How do they find opportunities?
With us, it's easy because we've got a conduit through you, Joe, and you, Leanne. And sometimes, like this, I sent you an email, Leanne, saying, would you be able to be on a panel for our grants? But we would like to spread the net a bit wider. A couple of years ago, we ran a big workshop where we paid for consumers to come in and give us advice. Budgets are a little tighter now, but we should do that again maybe. There's a couple of hows. When we come to you, Leanne and Joe, with our research grant ideas, before they get written up into a grant, maybe we could have a Zoom like this and seek advice. We'd like to do more co-design of our research grants, for example. So there's a few hows. Really, you know, I would turn that question back to Joe Root if I could have the temerity to do that. Joe, have you got anything to say about how? Because you're right in the epicenter of this. You often have more good ideas per cubic centimetre than anybody I know, maybe except Leanne.
And Tony.
And Tony. Not to forget Tony.
That's very.
So there's some ideas from us. Do you want to add to that, or Yvonne?
Yeah, look, oh, sorry, Leanne, you would.
Oh, you go, Yvonne. I was just going to, well, I'll say what I was going to say because then you can probably jointly respond to that. I guess, you know, I mean, I'm not asking you to speak on behalf of the whole research community, but that's sort of, you know, your philosophy and practice, and you're evolving that. But I suppose the challenge is, how do we get all of the research community to have, you know, a similar philosophy and practice to yours? It's all very easy to say consumer participation and involvement in research, but how is that supported and done in an authentic way, you know, across the research community more universally?
So if I could say, I'm on the research committee of NHMRC, okay, which is one of the peak bodies of the National Health and Medical Research Council, to advise the research community and advise government. Your statement, the CHF statement, the joint one with NHMRC on research participation, is the galvanizing document for every research grant that now goes through NHMRC. So I wouldn't understate the amount of influence you've already had on the research community with your views on the consumer needs to be at the center of this. But I do think there's a lot of groups that perhaps aren't as advanced as we are perhaps in our thinking, if I could say it that, maybe because we've been so influenced by CHF. But I think this is a journey, and I think eventually lots of people will be saying the same philosophy that we are about the patient at the center. I think this is a journey. We're probably just slightly ahead of the curve from many places. Gaston, you wanted to say something.
Yeah, I mean, we applied for a grant earlier this year, which was, there were a couple of grants from Cancer Institute New South Wales, another from Cancer New South Wales, Cancer Council New South Wales. And any grant that you go for from Cancer Council New South Wales has to have evidence of consumer consultation in it. So I think structurally, CHF should consider perhaps lobbying grant providers to make that kind of requirement, or to consider making that kind of requirement, using Cancer Council as an example. The secondary point I'd say is then dealing with the other issue of, well, what do you do when you're a consumer and you're in a room full of these academics speaking gobbledygook? Then you just have to be strong about your experience and demand clarification in the language you can understand. It's the same as the patient with cancer who needs an answer about their care. You know, they're entitled to an answer they can understand.
I think one of the most powerful things consumers can do when they're sitting around the table, like Gaston says, and everybody around you's got a PhD or they're a professor or something like that, is tell your story. The most powerful thing is to tell about your experiences with the health system. It's important for providers, clinicians to do that. It's really important for researchers too, because we honestly react to that and we put that into our grant and we take that into account when we're doing the next research question we want to answer.
Yeah, the other thing I was thinking of just as we were speaking is that although we have this statement now from the NHMRC, it needs to be implemented. So we need an implementation plan led by consumers and involving clinicians and researchers and managers and policymakers. So having a statement is the first step, but we actually need to implement it broadly.
That's right.
Others with us.
Yeah, as we often say at CHF, it's implementation, implementation, implementation. You mentioned that, and I would just give a little plug to our Shifting Gears Summit that's coming up in March, which will be a virtual event. You're presenting again. We've also got presentations as part of that program from the Australian Health Research Alliance, which is I suppose the peak body equivalent, as you would know, but our participants online today might not, for all the NHMRC translation centres. So that organisation, ARA, and the Australian Clinical Trials Alliance are going to be presenting alongside Jeffrey and his team and lots of others on the how question, and how do we translate the principles that are in that NHMRC joint statement into practical examples and practical ways of improving consumer and community involvement in research in a dedicated stream in that summit. We've got a consumers involvement in research stream running right across the 2 days. So I might just go to a few more questions here. Sorry, bear with me. Right, I'm just going to pick them at random because there's no particular priority here. I think it's important to share with the audience that the models you develop, i.e. the PRIME model, can be utilised in other disease areas, not just the one that was created in epilepsy. They are transferable. Is this correct?
That's absolutely correct. Whoever wrote that has hit the nail on the head. In fact, something like the PRIME model we feel is actually very transferable initially to other neurological diseases, but really the sky's the limit. Now, once you come up with a model, you need to make sure that it is adaptable to other conditions. And that's part of the strength of this kind of model, that it's applicable across the board, because it comes up with some major insights into what a patient-driven model might look like. And that really surpasses just one specific area of health.
Thank you. And just to answer, just another point to make on the comment before about how in practical terms, how do consumers become involved in research? We do have, and its convener is James Ansell here at CHF. We can put his contact details in the chat. James is he's our communication, what do you call, what's his, science communicator, research policy advisor. He convenes a research and data special interest group at CHF. So consumers that are interested in becoming involved and being, put forward when we get approached for
by researchers for consumers interested in being involved. That's one avenue. And of course, we do currently, as CHF, advertise across our networks and members, you know, when we're approached by universities for consumer advisors or participants as well. Susanna Morris said, re-involving consumers and telling your story. I found as a consumer representative that researchers, policymakers and providers are more responsive if you can locate your story within a broader consumer perspective. Just telling your story as an individual can be partisan and dismissed as such. For consumer experience to be used as evidence alongside other quantitative and qualitative sources, one voice, one story can be counterproductive and confirm the prejudice of many that consumers cannot see the big picture.
That's a really interesting point that's been raised, and certainly that was, you know, that was something that was recognised in the project I talked about. So we talked with, you know, a broad group of representative families when we were developing and co-designing the kids' GPS integrated care model. Because you're right, you can't rely just on one story. And I think, you know, most researchers actually recognise that you need to have broad views, and you look for the sort of commonalities that you can then address through change within the system, according to what, you know, the families say.
I think we also, you know, in the Australian Institute of Health Innovation, we pride ourselves in ensuring that we not only look at consumer stories, but we look at the picture in a range of different ways, and then we draw all the data together to tell a bigger picture, to tell a larger story, to be much more comprehensive. And so it's unusual for us to just do one thing. We're often combining and contrasting one kind of data with another kind of data, so that we do make sure that the data is corroborative in that way that the person who sent in the question has described.
Yeah. And also, you know, it's not just about CHF either. I'm just looking at a comment here from one of our member organisations, Elizabeth Kochman from Cancer Voices New South Wales. A lot of our member organisations, and Cancer Voices New South Wales is one example, who run consumer involvement in research programs as well. So they've been running theirs for 15 years. And you mentioned those, Gaston. And the NHMRC, I do believe they have some resources now on their website that are more focused on the implementation of that joint statement, some guidance and things like that. So if Anthony's listening in, we might put the link up to those in the chat box as well as a set of resources for people to have a look at. Just one for you. Again, I'm just picking these off at random. Janelle Bowden, a question to you, Yvonne, or comment and question. I imagine anyone caring for someone else would love a similar system to that described for patients and families, not just those caring for children. Is similar research being done for patients and or carers in other settings, such as ageing and aged care, disability services?
Yes, absolutely, it's being done. And New South Wales Health in particular has a program where they're rolling out integrated care in many different areas for people with chronic complex conditions. So yes, it's definitely happening. Oftentimes though, unfortunately, the evaluation component is not always as well developed as it could be, and so it's quite difficult to show the, you know, unequivocally that the, you know, the benefits of these new programs. So we need to be improving that constantly.
And we've got a comment here from Deborah Lettiker. I mean, and often it's you know, it's traditionally been the case that consumers are you know, engaged in fairly tokenistic ways, or engaged at the back end of a process where the research has been conducted and the findings are being discussed, and that's good that they're involved at that point, but we advocate that they should be involved right throughout the research cycle. Deborah's asking, she said, great presentation, but she's also asking, how do you decide
which research you undertake at your centre? What processes do you use?
So it's like a triangle. So on the one hand, our own experience at doing research, and as we do research, it often occurs to us, what's the next research question as we get the results from that particular study or studies. So that's one thing. Second thing is, we look in the literature and say, okay, what do we already know? And then what gaps are there? And then the third bit of the triangle is, well, what about all the stakeholders we work with? What are their research questions? And that's where CHF comes in. I was going to throw back to CHF to say, if you, during some of your workshops or the things that you're doing in the next year or so, if you have research questions that you want to generate and throw at us or other people in the system, I think that's perfectly legitimate for you to do. Not wait for us. I think embedded in the question is often you're waiting for us to come and invite you onto a research project or to do some co-design. CHF's big enough, smart enough, and respected enough and powerful enough now, I think, to be able to say, here's some research questions that we think you people in the research community need to be doing, which would have powerful benefit for patients. So we'd be delighted if you were to give us things that we could then take and run with.
Yeah, and it has been and we can do, I mean, you can always do things better and differently, and it has been commonplace for us with our Thought Leadership Roundtable series that you've been involved in, to involve relevant researchers, one, to give us an insight on what we do know from the evidence base, but also to be there and be party to the conversation about where some of the research gaps or research opportunities might be. So we can certainly look to do more of that. Probably time for one more question, and this one's from Georgia Gardner. Georgia's part of our Youth Health Forum, and she's asking, what advice would you give to young health sector students who would like to bring an it's a long day. Bring an implementation science approach into their tertiary education that may not have had this model embedded yet?
Yeah, look, you're really at the cutting edge, even asking us to give this workshop, even saying to people who are doing implementation science for a career like us, to invite us to this workshop. You're really ahead of the curve. Lots of people aren't there yet. Then the implementation science is just a phrase. They're just words. So if you're young and keen to and doing tertiary studies, maybe an undergraduate degree, a master's degree, or a research degree, look, start to think about it. Implementation science is, as we've said, about how do we change the system for the better. Try to think through the essays you're doing as an undergraduate or a master's student or as a research student, the research you're doing. How can I make this pack a punch? How can I make this deliver a better health system or contribute to that? And if all else fails, send one of us an email. We'll be happy to have a chat with you.
Thanks, Jeffrey. Thank you to you and your team for today. I'll hand back to Tony now to formally thank you. There is information now in the chat to those NHMRC additional implementation support resources, and also about CHF's research and data special interest group, if anyone's got an interest in finding out a bit more about that and talking to James or Joe about that.
Leanne, if there's anything else we can do to help, just, we're only a phone call or an email away.
Well, I think we've had a very nice taster of further conversations we're going to be having about all of these issues and more in the consumers and research stream at the summit. And we certainly value our partnership with yourselves, and it was great to jointly publish that document that was that report that was released today too. So thanks again, and back to you, Tony.
Yeah. Thank you, Jeffrey, Yvonne, Francis and Gaston for a very, very good presentation on implementation science. And it just highlights the need to involve consumers in co-design, not just in services, but in policies and so forth. So really good stuff. Thank you very, very much. Appreciate it.
Thank you, Tony. And we'd like to thank Isabel Mollenbrook for helping us with all the slides and doing all the background work. The unsung heroine.
Excellent. Okay. Thanks very much, Hannah. Okay, that brings to the end our Members Policy Forum. And for those who are going to attend our AGM, we hope there's lots of you. We'll be starting at 2:30 Eastern Standard Time or 2 p.m. Central Standard Time. Okay, I'll see you soon. Thank you very, very much. Bye-bye now.